Welcome, everyone. My name is Shirley, and I will be your moderator this evening. Tonight's webinar is Unlocking Dental Success, Mastering Dental Claim Coding and Documentation. I am excited to welcome Dr. Greg Grobmyer, Senior Advisor and Editor-in-Chief of Practice Booster, and he is our speaker this evening. So welcome, Dr. Grobmyer.
Thank you so very much, Shirley. I appreciate it.
Before we get started, I would just like to, sorry, Dr. Grobmyer, I just want to take a moment to go over some quick housekeeping. If you have a question, please, we invite you to go ahead and type it into the Q&A box at the bottom of our screens. Dr. Grobmyer is going to address them at the end of the webinar. CE is not available for this webinar tonight, but anyone who registered, we will be sending out a recording. So this conversation is being recorded, and we will be sending out a recording of the webinar to everyone who registered. And with that, I welcome again, Dr. Grobmyer. We thank you for being with us, and I will pass it over to you now.
Perfect. I greatly appreciate it. Thank you, Shirley, for everything. And so first, just a brief introduction and who the heck is talking to you tonight. I'm Dr. Greg Grobmyer. I was a clinically practicing dentist in West Tennessee for about a decade. I went through a cancer battle when I was just 36. And so unexpected, no family history, anything like that, but went through some surgery and chemotherapy. It left me with peripheral neuropathy. So I've got numb fingers, numb feet. Couldn't do the clinical aspects of things like I was doing before. Had to step out of clinical practice and into doing some other things. I did coaching and consulting for a long time. I got into industry writing and writing for dental publications and journals and websites and blogs, but also for a lot of consumer-facing stuff. I got to write for Reader's Digest and for Slate and Men's Health and New York Magazine, some fun stuff. So got to do all that. That eventually led me over to working with Dr. Charles Blair, who if you've been in dentistry for any length of time, you're probably familiar with Dr. Blair. He is kind of the GOAT, the greatest of all time for dental insurance-related matters. He wrote the original Dental Coding with Confidence manual that's been going on for a long time now. And that book has expanded from just being about 100 pages to being about 400 pages that we are producing every single year. And so got to work with him originally as the Insurance Solutions newsletter editor, eventually took over writing that publication, and then working with him one-on-one on writing the Dental Coding with Confidence manual. So we've got the only book out there that kind of not only shows you what the CDT codes are, but also how to use them and how insurance will be affected and what the narrative needs to be and what the documentation needs to go with it. So that book is a great resource. If you're not familiar, I'd love for you to go check that out. So worked with Dr. Blair for a long time. Unfortunately, we lost Dr. Blair in November of last year. And so not sure if you were aware of that or not, but wanted to let you know. So I've stepped into some big shoes, doing all the coaching, consulting, and forward public-facing speeches. I fly around the country giving lectures on this topic, and so it's new and it's near and dear to my heart, and something great that I like to talk about a lot. So with that, we're gonna kind of move on into the presentation itself, but I want to thank my sponsor tonight. It's eAssist. Now, my company is called Practice Booster, but eAssist is a parent company of ours. We all fall under the Henry Schein flag. So eAssist has been around for a while. They've been around for 10 years or more, longer than that now. They've collected over, this bottom line there is the one I want you to focus in on, $17 billion, billion with a B, dollars from insurance companies on behalf of dental practices across the nation. And so it was started by a dentist, a wonderful man, Dr. James Anderson, who saw this need that really wasn't getting fulfilled within the dental practice, and that was the ability to outsource certain aspects of your practice that don't have to take place within the confines of your physical facility. And so he was one of the first, if not the first, to really start a business that did this exclusively. So they've been doing it longer than just about anybody else. And that's where they got their start was dental insurance billing. That's probably how you know them best, but that's not all they do. And so I want to kind of just give you a brief overview of eAssist before we dive into our actual topic this evening. So eAssist provides a lot of different a la carte services for their clients. And so any of these things that you're interested in and maybe kind of finding someone outside of the practice to take it over and look at this particular aspect of your practice, it's a great way of doing that. Insurance, billing, and aging, again, was their original focus. That's still their sweet spot, and they do it better than anybody else. They do it very, very well. And so billing and aging of insurance, but not just that. They do insurance verification, including specialized forms. If you've got particular questions that you want them to ask for your particular practice, they know how to do it. They know how to do it extremely well. So looking for eligibility, you're not paying someone at your front desk to just sit on the phone for an hour trying to get insurance verification. That can be done elsewhere. The people who are within your practice have the ability to focus on the patients who are in the actual office. And so it's a great way to kind of make great use of your time and your people that are there, especially in this age where there's turnover. It's difficult to find people to work in your dental office. This is a great way to outsource to people who already know what they're doing. They're already kind of experts in this field. This is all they do all day long. So we are all very happy as dentists to be able to have an endodontist if it is a root canal that's beyond our abilities, or an oral surgeon that we can refer out to when the extraction is a little more difficult than we care to get into. So eAssist is similar. They're the experts. They're the specialists of these particular subjects. And so we want to be able to refer out these particular obligations to someone who's not within the practice. Don't have to train them. They already know what they're doing. They're going to do it incredibly well. They're going to take care of you. So patient portion statements and billing. So not only are they talking about doing insurance billing, sending out claims, they're also talking about following up on patient statements. They do collection calls on your behalf. You don't have to have that ugly phone call. This can be done outside there. They do billing. They do practice accounting and bookkeeping and payroll. They do have CPAs that they're working with. It's not just someone trained there at eAssist. They are certified public accountants that they're working with to do bookkeeping and payroll, EFT and deposit reconciliation. And then they have a program called Full Schedule. They actually go through your practice management software. They can look within and see what patients have had diagnosis but have not been put on the book for actual care. And so they help you to fill your schedule and keep busy, which is a critical thing these days. So that is eAssist, and we'll talk more about them at the very tail end of this conversation as well. So let's go on. We're going to talk a little disclaimer here. Coding is constantly changing. And so the things that I'm talking about today are true as of today. To the best of my knowledge, these things have been researched. It's accurate as of this date. I can't say that, tomorrow there's not a law that's going to change, or that there's not going to be something handed down from ADA where something is altered. In fact, a lot of coding updates happen mid-year. And so those are things that we're watching for. So always code what you do. This is what we call the golden rule of coding. That's making sure that you're accurately representing the procedures that you are performing, and follow the CDT code set to the best of your ability. There are situations where there's strategies to coding, where one code or more than one code might fit, and then you've got to know which one is going to be better for you, for the patient, and for the situation. So we'll talk a little on strategy as well. The presentation is for information only. I am not an attorney. This is not legal advice. If you do need legal advice, please consult a healthcare attorney within your state. So every state is different. So tonight we're going to be talking about essentially 3 different things. We're going to be talking about coding and coding strategies. the things that you need to do to make sure that you're doing it correctly. We're going to talk about the importance of documentation and lots of different reasons why that's important. We're going to discuss that thoroughly. And then how it can all maximize your insurance reimbursement. So it all comes down to that. It's going to come back to maximizing the dollars that are coming from the insurance company and back into your pocket. So one great thing about doing this correctly is that this is a way to increase revenue for your practice without seeing a single extra patient, without doing a single extra procedure, okay? We're wanting to just make sure that you are actually getting what is rightfully yours to begin with, but we got to make sure that you're doing it in the right way to get that done in a timely manner and with maximum reimbursement. So that's our discussion for tonight. So quick poll, going to give this about a minute. Do you currently use some type of a coding resource? So that could be, the polls popped up right now, so it's just a yes or no question here. Have you got one of our books from Practice Booster? Do you have the ADA's CDT manual? Are you looking at some form of a reference book that is up to date to help you know how to code correctly and report correctly? So that's going to give just a minute more, and then Shirley, you can let me know when this is wrapped up. I believe it was a 60-second poll. Got some numbers coming in?
That's right. And we still have about 20 more seconds left, a little less than 20 seconds. But so far, it looks like overwhelmingly our respondents currently use a coding resource, about 77% of them.
Oh, that's fantastic. That's good. That's good.
Just jumped up to 79%. 79% do, about 21% do not. And we are closing the poll.
Okay, so there's 20% of you that need to get your hands on something that's a little more updated. So, yeah, it turned out to be 79% to 21%. So the vast majority of you are using some type of coding resource. The next question is the thing up to date? Okay, that's another consideration. You've got a book, look and see what date's on the front of that thing. Codes are always changing, and so if you've got a book that's a year or 2 or 3 years old, there's things in there that are not correct anymore. And so that's certainly a consideration. So correct coding. This is my buddy, Dr. Charles Blair. This is my mentor, my guy, my guru. Correct coding can result in higher revenue because you're getting reimbursements that were going unpaid because of misunderstanding or misreported codes. And so we're going to help you understand these codes, how to truly meet all the criteria that are necessary to properly code, avoid audits, protect yourself, and maximize reimbursement. So, all right, coding for what you do. First, code and report for what you do. This is kind of the golden rule of coding. Like I said, we want to make sure that you're accurate in what you're doing, that you're not changing or misrepresenting what it is, the procedure that you're doing. We want to make sure that things are accurate and coded correctly. So codes are not specialty specific. There are no codes that are just for orthodontists or just for periodontists. All these codes can be used by anyone who has the training and the proper credentialing to provide that particular service. And so nothing is in the realm of specialists. There's no code that just is for one particular type of dentist and not another. So anybody can use these. And they are updated annually. I get to be a participant with that. I get to go to the Code Maintenance Committee meeting, which happens in Chicago every single year. So we'll talk more about that in a second. So this is just the last few years. Take a look at this. If you do the math here, this is over 200 changes since 2020. Okay. And so again, I encourage you to pick up the book that you've got, take a look at the front cover. If that does not say 2024 on it, you probably should be thinking about getting some form of an updated resource to look at, because there's going to be something there that's incorrect. 200 changes since 2020. That's a lot. Okay. A lot of them are brand new codes. You can see that far left column. There's a ton of new codes that are out there, and a lot that have been deleted. Every time I work with a practice, I do a lot of one-on-one consulting with offices. We do what's called revenue enhancements. That's where I will take a practice's coding reports. I'll do a Zoom call. I'll take 3 full hours of time going down the coding and teach, yeah, you're doing this one, you're doing this one correct. This one is a deleted code. It shouldn't be there. You're not using this code because you've never heard of it. And here's what you need to do. Here's your attachments. Here's your proper narrative that needs to go with this, what documentation. So we do this intensive little 3-hour training on coding and correctly documenting and reporting. And invariably, I've yet to see an office that was doing everything correct, that was utilizing all the potential codes that they possibly could. Most often, there's at least 1 or 2 deleted codes that are still getting reported. And what happens if you send in a deleted code to an insurer? It immediately is denied. Immediately. It won't even get through to an actual human. It'll get kicked out by the computer before it even hits human eyes. And so staying on top of these things and making sure that you're using the current code set is absolutely crucial. So moving on. So where do CDT codes come from anyway? What is that? It's current dental terminology, and all these things are directly from the American Dental Association, okay? Now, the ADA is responsible for putting out the code set. They're not the ones that are just totally creating them on their own, though, however. There's a group called the Code Maintenance Committee. They meet every year in March. There's 24 voting members on this committee, and only 5 are from ADA. 5 are from ADA. Then there's all the 12 dental specialties are there. There's a lot of other dental organizations like the AGD or the American Association of Dental Plans is there. There's a lot of payers who are also represented. So Blue Cross Blue Shield has a vote. Delta Dental has a vote. They're on the committee. Now, overwhelmingly, we have dental representation versus dental payer representation. So if we want a code get passed, we can usually get the code to make it through. However, that doesn't mean the payers are going to pay it. Those are 2 different conversations, and we will discuss that a little later on. So ADA meets and votes on these updates to the codes, which the updates are turned in from people like you. Anyone who wants to, if they feel like there's a void in the CDT code set, can fill out a little form on ADA's website and send that in. As long as it's sent in by November, it is then looked at the next Code Maintenance Committee meeting in the following March. And so then that will be voted on. It might be yes, it might be no, it might be tweaked. A lot of times they'll change some verbiage or make it a little different if they still feel it's a valid code change. So this could be removing a code that's no longer serving its purpose, could be adding new things, or could be revisions to codes that are already there. So sometimes you're using a CDT code and the verbiage has changed. You don't realize it. You may not be meeting all the criteria anymore to properly document that code. So what is the point and purpose of CDT? It's a universal language. This is the language that's been established as, the government has said this is the language that meets HIPAA. This is the language that should be used in all electronic health data interactions and everything. So if you'll notice the top line, the CDT code performs uniform, consistent, and accurate documentation of services delivered. That is the primary purpose of the CDT. And because of that, so CDT is a way that it's a language that we all speak. That way, not only will the other doctors or providers within your office, your assistants, your hygienists, they all know what you're talking about. So will the specialist when you're sending something out. They understand what that code language means. As a legal document, the CDT stands alone. Okay, so you may have in-office codes that you're using things for, and those are great for administrative functions, for things that go on behind the scenes, and for just documentation purposes of administrative duties. But if it's a procedure, if it's a thing that has a dollar value on it, there's some form of CDT representation that's going to fit it, okay? And it's the right and the proper way to do it, not using those in-office codes that you've made up. Those are internal. They are not a uniform language. They can't go out to everywhere else. And so even if you never messed with insurance, you were never sending insurance out, or you never filed on behalf of your patients, you still have an obligation to be using the CDT code set as the language that you are speaking. That is the legal language of dentistry. And so it just happens to also be the language that we use for the processing of dental claims. So it bugs the heck out of me when people call these insurance codes. They're not, okay? This is the language of dentistry. And so it needs to be thought of as such. This happens to also be the language we're speaking to the people at the insurance agency. So let's look on. There are 3 parts to every single dental code, okay? Now, not all of them have all 3. All of them do have the first 2, however. That is the procedure code itself. In this case, this example that I'm showing you, D0120. Okay, so that's the code. The nomenclature is this top sentence here. Now, this is probably what you see when you open up your practice management software and you're looking at, what the codes are. You're trying to figure out which code it is based just on the nomenclature. It may not give you all the answers. So this particular one is periodic oral evaluation on an established patient. So that's there. That's fairly clear, fairly straightforward. But then they go on to give you a descriptor. Since the 1990s, they've added descriptors to, I won't say the majority of codes, but a lot of the codes do have descriptors attached. And so that's a full-out paragraph. So not only does that paragraph give you a little more clarity as to how the code should be used and what all that nomenclature means, but it also establishes criteria which you have to meet and document in your clinical notation to say that you actually delivered this thing correctly. Okay, so for instance, all right, we're looking at this code. If you're looking down at the descriptor, evaluation, it's a patient record to determine changes. All right, note, this includes an oral cancer evaluation. Okay, that's a must. It has to include an oral cancer evaluation. So every time you do a D0120, what should go in your clinical documentation? You need to write down in some form or fashion that you are doing an oral cancer evaluation. Now, that might be writing OCE in the clinical chart, or that might be using an actual, CDT code, if there is one that's represented for a particular type of consultation that's required. But oral cancer evaluation is required now for all the evaluations, or the comprehensive type or the periodic type. The limited does not have this language, but the comprehensive and the periodics do. So oral cancer evaluation is a must part of that. That means, first off, if you're saying you're doing 120 and you're not writing down that you did oral cancer evaluations, theoretically, an insurance company upon audit could look at your chart. They could say, oh, you have not written down that you did oral cancer evaluations, even if you did them, but you didn't write it down. It didn't happen. Okay. And so if that's the case, they have the ability to take money back. If you do not meet all the criteria of a descriptor and write that stuff down in the clinical notation, then they have the right to take money back. Okay. Outside of that, think about, heaven forbid, a patient does come up with oral cancer. You got a patient who 5 years from now is now suing, a malpractice type suit towards your office, saying that you missed this. What's the first thing an attorney is going to do? They're going to pull out your clinical charting. They're going to look at that. They're going to see, did they write down that an oral cancer evaluation was done? Because if you didn't write it down, that means you didn't do it. And that means you were negligent. And so even if you are doing these things, you have to be sure that you're writing them down or it didn't happen. So being conscious of the descriptors of these codes, because you never see them. You don't look at this. You don't see this when you look at your practice management software. You kind of have to get familiar with the code set, the codes that you're actively using. Most offices are using around about 100 codes, some, as little as 60, some as much as 150. But those codes out of the code set that you are regularly using, I would look up those descriptors. I would read them. I would see what the criteria are. There's certain ones that require counseling. There's certain ones that require, specific things to be met, or else you don't get to count it. And it could be give you trouble on an audit. So moving on, incorrect use of dental codes is a major cause of claim delays. Absolutely it is. Coding errors is a particular problem that we see with a whole lot of offices, and I want to make sure that we're correcting that. So coding errors, there are some common coding errors: misuse of the nomenclature or descriptor, writing down the wrong one, calling something that it's not. And so I see a lot of confusion about 9310 being used for consultation. Well, it's not just a general consultation. If you read the descriptor, 9310 actually requires referral from another healthcare provider. It requires you writing a report back to the referring healthcare provider. If you're using 9310 as your normal consultation code, you're probably doing something incorrect within your office, okay? More than likely, that ought to be eliminated at D0140. And so that can be used for consults if it's a one particular subject that you're discussing with the patient. So if you're just looking at discussing implants or discussing ortho or discussing cosmetic veneering, that could be a limited oral evaluation. So make sure you're using the right code for the right thing. So incorrect arches, incorrect quadrants. There's a document on ADA's website. It's called Reporting by the Area of the Mouth. I can't remember the exact verbiage. It's yay long, but wrote about it in this upcoming Insurance Solutions newsletter, as a matter of fact. And so it breaks down every single CDT code and whether you should report by arch, by quadrant, by whole mouth, by surface, by tooth number. Do you need, what do you need in order to properly document that you did that on that claim form? So that has to be correct. Incorrect age definition. A lot of the, imagine a prophy. There's a child prophy code. There's an adult prophy code. Most of the insurers are going to break that apart based upon an age, usually around 14, let's say. However, if you look at ADA's definition of the difference between the two, it falls upon dentition. And so if you have a 12-year-old, but they have all their adult teeth, they have no primary teeth remaining, that's a D1110. That is an adult prophy, even though they are 12. You can submit it as such. You just need to write a narrative that states that this is not a child because they don't fit that criteria by their dentition description. So incorrect age definition. You got to make sure you call them what they actually are. Expired codes, we're talking about deleted codes. I see people are using 6052 for implant locators, and they've been using it for years. So it's not that anymore. It got split up to 6191 and 6192 as two separate halves of an implant locator. Well, if you're still coding for D6052, what's going to happen? Immediately kicked out, immediately denied. You're never going to get through and get that claim paid. So, or an incorrect exam code using a periodic instead of a comprehensive, using a comprehensive oral when it really could have been a D0180 comprehensive periodontal evaluation. If you hadn't listened to my podcast on the Dental Code Advisor podcast about using D0180 and D4346, check out the Dental Code Advisor podcast on that. That's a moneymaker. In about 20 minutes, you can learn how to really, really do some great things for your practice. So make sure you're using the right exam codes and for the appropriate situation that's going to maximize your reimbursements. So This is a mistake I almost made. Looks pretty similar. So coding errors are one type of error. People make errors all the time. Now, granted, cortisone probably would take care of inflammation, but I don't know that would have been a great idea. So documentation. I talked a lot about coding. Coding is kind of my sweet spot. That's my area of expertise. Documentation for these codes, however, is another critical aspect of making sure that you're not only doing what needs to be done to meet the criteria of the code, it's also to make sure you're getting your claims adjusted. It's also making sure that you're protected. And so it's the cornerstone for maximizing legitimate reimbursement. You got to have the right documentation for these codes in order to justify the work that you are doing. So we'll talk about specifics on that in a second. So why is it so important? Documentation is, first off, for continuity of care. It's making sure that you know what you did last time, you know what you're going to do next time. The hygienist knows what the doctor's doing and vice versa. We can look at the chart notes within our own office and we can see what we did. It's communicating from the back to the front. We know what's happening within the office, and that's wonderful, okay? But it also is crucial for increasing your legitimate reimbursement. If you don't have the right documentation for those core buildups, if you don't have the right photo set, the right keywords, the right narratives, those are all things that we talk about in our lectures and in our consultations. Those are very specific things that need to be included in order to actually get that claim to go through and to go through on the first time without any trouble or pushback from the insurance companies. And so it has to be there, and it has to be there the right way. Also protects and defends. Remember what I was talking about just a minute ago. Heaven forbid you ever have a lawsuit from a patient, but the first thing they're going to do is go to your chart notes. And so I don't know of a practice that probably charts enough, honestly, including just every little detail you can within reason about what was done with that patient that day is a crucial thing to make sure that you are protected. 5 years from now, you're not going to remember what you did this day. You're not going to remember the anesthetic that you gave or how many carpules. You're not going to know how much nitrous did you give this patient, whatever particular aspect of this is going to happen. And if they can show that you are deficient in your documentation or in your note keeping, that's a lawyer's dream, okay? It's also an insurance auditor's dream. Heaven forbid they're coming in your practice looking at stuff. But if you have thorough and comprehensive documentation and they see that, they're going to be a lot less likely to audit you. They know they're going to have a hard time proving that you're deficient or delinquent in something, okay? If you're just writing just very sparse chart notes, they know they've got a chance there to maybe make it worth their while to go try to collect some money from you. So be sure that your documentation is absolutely backing up not only what you did, but why you did it, and then how you did it. And so all those things need to be in the chart notes. There's all different types of documentation. So the chart notes themselves are critical. That's the responsibility of the clinician. The chair side is helpful. Templates are great. Make sure that you're altering them, though. You make them specific for the patient that's being seen that day. Don't just use rubber stamp chart notes and have the same type of verbiage on every single patient. That's not going to hold up in a court of law, okay? Radiographs, photographs, these are things that are irrefutable evidence. And so taking a photo before you sit down and prep that crown, it shows the reason why. It shows things that may not, if you have an intraoral photo, that's going to show some things that may not show up on the radiograph, and vice versa. The radiograph's going to show things that don't show on the photo. So all those are important bits and pieces. Periodontal charting and tooth charting, those are all things that you're wanting to show existing restorations, you're wanting to show disease process and its progression. All those things are critical. And then the narratives. The narratives should be pulled directly from the chart notes. In fact, seeing a big increase in insurance companies actually wanting to see the actual chart notes from the date of service. So be sure that that's being done correctly in the back. Docs, this is up to you. You're signing your name on this, okay? If somebody else is filling out your chart notes and then you're signing your name, guess who gets in trouble if something is not correct or not there? It's the doctor, okay? You're the buck stops your person. You've got to make sure what's going in that legal document is correct, okay? You're putting your name on the line that this is truthful and factual as to what happened this day. The narrative then can only be pulled from things that are in the clinical documentation. You shouldn't have anybody at the front desk who is adding to or elaborating on the procedure with information that was not directly in the chart notes. The chart notes is all that happened that day, and that's all that can be pulled from. So the person who's writing the narrative can only pull from that chart note. Okay, things carriers want to know. So this is insurance companies, including auditors. What are they looking for? Was it actually performed? So let's say for a 4-bite-wing set, D0274, you've got, you're submitting that to the insurance company. So they're going to want to see that there were 4 separate bite wings there. They like to look at those. But then they also get the chance to look and see, are they diagnostic? Do they actually show what they're supposed to show? Or, did you break the contacts on this particular thing? In the chart itself, were these ordered by the provider? That needs to be written down. That needs to be the reason why you took those radiographs. And if you're writing stuff like patient wasn't due for radiographs in the chart, that's not good. What you're saying is that you're allowing insurance to dictate treatment when really it should be dictated by the needs of the patient. And so it has to be ordered by the provider. So you need to write down Dr. Johnson requested a bite wing set to look for interproximal radiographs. Write something like that down. It could be in the templates, okay? Just that those were requested and why they were requested, okay? They must be diagnostic, and then they also must be reviewed. You have to have some type of a finding. So if you say there's no caries, or if you say there's, bone level is normal, that's implying that you've looked. But, so no findings is also an answer. But if there are findings, those need to be noted. So all those things need to happen every time you're taking a radiograph. So only then, if all the bits and pieces are there, did you actually meet all the criteria of the code. And then the procedure was actually performed. So the next thing, was it medically necessary? Okay, we've got, you have to kind of prove that what you're doing was done for a reason. So if you're doing SRP, for instance, you're needing to show that there was a disease process that was happening. So there is bone loss there. Was there calculus? Is there mobility? Is there furcation? Your periodontal probing and charting is going to indicate a lot of that. But the bleeding on probing is becoming a big thing because that's showing active disease process. Even though bone loss is forever, inflammation can be episodic. Payers don't normally pay unless they're seeing signs of active disease process, which is indicated by bleeding. So if they're not bleeding, they may not pay on that SRP case, okay? So they've got to have, and then they've got to meet the certain criteria of the particular plan. So what about, was it cosmetic? Okay, if you're doing fillings on front teeth, let's say you do a, big 4-surface plus anterior composite resin. So was it for reasons of decay or was it to close a diastema? Okay, you do have the ethical obligation to actually tell the insurance company if it was for a cosmetic reason. And if it was, they normally don't cover cosmetics. And so unless they've got some type of specific cosmetic rider, which there are few and far between, but if there was no decay or fracture or some other need for that tooth to be restored, if it was just done for the purposes of appearance, they don't have to pay for that. So, but you do have an obligation to report if it was done for the purposes of cosmetics. So what about, was it upcoded? Okay, that means taking or reporting a higher code than what it was that you actually did. Let's look at the surgical codes. Let's say a 7140, that's your simple extraction. So that means anytime that you're pulling a tooth and you're able to elevate it out without taking away bone or things like that. So if you can move the tooth with just an elevator or forceps, that's great. That's a simple extraction. Even if it's just the root, if the crown of the tooth is missing, you're able to elevate it out. That's still a simple extraction. Only when it becomes a situation where you are removing bone or sectioning the tooth does it become a 7210 or surgical extraction. And so in that circumstance, if you're manipulating hard tissue, if you're taking away bone, if you're cutting the tooth into pieces, that becomes a surgical extraction. Laying a flap does not make it surgical. Putting in sutures does not make it surgical. Those are soft tissue things. Those can still be done along with a simple extraction. It is only when the bone is removed or tooth is sectioned that you're talking about a surgical extraction. So that could be upcoating. If you are not noting in your chart when you do a surgical that you took the bone away or that you sectioned the tooth, well, you haven't met the criteria of that 7210. Okay, make sure that clinical notation is there. You've got a 7210, write down what made it a 7210. Okay, why did you call it that instead of simple? Put it in your clinical documentation. Otherwise, it could be considered upcoding. You are trying to call it something a little more than what it is in order to gain a higher reimbursement. You don't want to get in trouble for that. So then, was the claim form submission accurate? They're always looking for the information, comparing the dental record to actually what happened. It should mirror the same facts. So you've got to have the same treating dentist as the billing dentist. Okay? Don't be in that situation where you got a non-credentialed new associate and you're doing it on the existing doctor's NPI number. That's the one that because you're essentially lying on the claim form if you're doing that. Okay? So if you've got that period of time where the second doctor is not credentialed quite yet, you need to be getting them into the process of credentialing. Now, in some circumstances, you can actually let the insurer know they're in the process of credentialing and see if they will allow the patient or this particular thing to be billed out as if that new doctor would be in network. That's few and far between most of the time. That does not happen. So, but you do have the obligation to make sure that the actual treating dentist is the one that's on the chart note and on the claim form. And that stuff's got to match. You can get in trouble for that if that does not jive together. So lastly, was the procedure properly represented by the most current CDT code that was in the effect at the time? And so, again, if you're doing that D6052 instead of a 6191, 6192, they're going to kick that out. If you're using old codes that are no longer valid, then that immediately is going to result in a denial. And one more thing, there was one more thing. Did the procedure meet plan criteria for reimbursement? Now, I want to point this out. There's a difference between validly doing a procedure. They do qualify for this particular procedure. You can code for it. It meets all that, okay? But just because it does and you submit it doesn't mean you meet the criteria for reimbursement of that particular plan. So they can have periodontal disease and you send it into the plan and it gets denied. Well, they didn't have periodontal disease enough. They didn't have it to the point where it matched the plan criteria. Now, what that is that's set forth by whoever designed that plan for that company. So it's somebody in some smoky boardroom somewhere saying, these are the things I want my employees to have, and here's how we want it reimbursed, and these things must meet this criteria before we will pay for it, okay? So they can qualify and meet the code. They'll fit for the CDT code, fit for the procedure. You've diagnosed it correctly. You've got all your documentation. But if they don't have the right bone loss, the right amount of bone loss, or the right amount of tooth structure loss for a core buildup, then those particular procedures will not get covered or reimbursed based on the plan. And that's going to vary from plan to plan. It is plan dependent. So you've got to be able to know what the particular rules are of the particular plan. It's great if you can get a hold of the plan document for each one of those particular plans that you work with a lot. That way you have the rule book. You know what the claims adjusters are looking for, what clinical criteria must be met, what pieces of documentation need to be there for them to positively adjudicate and pay that claim. And so that's great to have. If you can have the rules of the game, it's a lot easier to win the game. Okay. Next, we're going to talk about radiographs and radiographic images. Again, you should always include these things as proof of clinical necessity. You're wanting to send, and you're sending them in as an attachment. You want to put that right there. If you can, a digital is best. They do still look at physical radiographs. They do. They are able to actually get things through the mailroom, but it's a much more complex situation. They usually end up having to scan things in themselves. A lot of times they're using AI now. A lot of payers are using things like Vidya Health or Pearl or Overjet to look and do evaluations of radiographs, see if they see the decay, see how much bone loss is there, see if they can see the problems that you're saying are there. And so, if you've got those tools, make sure that you're marking it up and sending that in where it's apparent for the claims adjuster to see. It's a lot harder for them to argue if you've got that form of documentation that you're sending in. So send these as proof of clinical necessity. Intraoral photos are critical. If you're not taking a lot of intraoral photos, for like 43, 46, scaling in the presence of moderate to severe gingival inflammation, take intraoral photos to prove that they have inflammation, okay? If you're just saying they have it without backing it up, they may remap that or downgrade that to a prophy, okay? So you're having to prove that it's not healthy gums. You're having to show that there's bleeding. And a great way to do that is to take an intraoral photo and send that along with the rest of your documentation. So that's that. For radiographs to be valid, I did mention these things. They've got to be prescribed by the clinician. You need to write that down in your chart notes. They must be of diagnostic quality. If you send in a PA that doesn't show the periapical area because it's cut off, they don't have to pay for that. And in fact, if you send in enough of them that are not of diagnostic quality, it can be an audit flag. Insurers going, hey, if these, images are here and they're in such poor shape that we don't have to pay for them. How many of these have we already paid for that we missed? So they'll actually go into your charts and start looking for things. And so we don't want that to happen. Send in diagnostic quality radiographs. If they are not diagnostic quality, don't count them, okay? Then they have to be reviewed and the findings noted in the clinical record. Okay, SOAP note documentation. This is the format that we like for dentists to be able to include everything that needs to be there. So subjective, and now you don't have to actually break this out SOAP, but do need to write, their chief complaint, the things that they say to you, that's subjective. The things that you observe with your own eyes through testing, that's objective. The assessment is going to be the diagnosis, your differentials diagnosis, the different things that it could be, and what you feel like it actually is. And then the treatment plan itself is going to be the last section that's going to be what you're going to do on the patient in the future and may include what you did that day. So all those things are there. We have a clinical documentation book, that documentation with confidence. And so love for you to look that up as well. It's a great way to just see examples of SOAP notes from each of the categories of service that are here. So understanding how to do these things correctly, how to properly report dental procedures, that's going to be essential to getting payment for these services. Want to make sure that you're really understanding the thorough, complete notes are critical, that the proper radiographs, the proper photos are critical. If you're not knowing what to send in, you can look at some of our resources. It's got it written there. You can also work again with eAssist. eAssist is going to be making sure that these things are being done. That's part of what they do, is making sure that that all the bits and pieces are there that need to go to get claims submitted correctly. So talk to your Henry Schein Field service representative. They can hook you up with our resources through Practice Booster. They can talk to you about eAssist and what eAssist can do for you as well. And so your Henry Schein Field Services rep can help you with all those things. Again, eAssist does a lot of stuff. And so we want to make sure that all these are a la carte services. You don't have to have all of them. You can just do one thing. It's up to you. So if there's one particular aspect of your practice administration that you feel like you want to outsource, let somebody else take a look at. This is a great way to do that, and have somebody that knows what they're doing already. They're already trained. You don't have to retrain somebody and pay somebody to sit on the phone within your office. There's somebody out there that can do it for you already. Okay. And Practice Booster comes along with eAssist. As a client of eAssist, you actually get access to our online code advisor service. Now that's, if you'll look at that one particular slide that shows you just kind of a little blip of it, but practicebooster.com, if you want to go out and see it a little more thoroughly, it's got breakdowns of every single one of the codes, what it is, a better description of how it should be used, what attachments are there, what narrative should be there, what common errors, common miscodes, all those things are there, along with the other resources that we offer as well. And so Practice Booster is kind of built into the eAssist process. So if you are interested in reaching out and learning a little bit more about eAssist, having somebody contact your office, you can please do so with the poll that's going on now. Shirley, if you got that pulled up and going, I'd appreciate it. And so that gives you the chance to just say yes or no, or even do it later on. Don't do it yet. And so if you would take a look at this poll that's here, and if we can reach out to you and discuss this more, we'd love the opportunity to speak with you. So that'd be a great thing. The practicebooster.com itself, you can reach out to us directly if you wish. We do have other services, including UCR fee analysis, our one-on-one coaching and consulting with our revenue enhancement program. We're finding on average like $100,000 for single doctor offices just due to miscoding and issues like that. So they more than pay for themselves to look at that and have that particular service done. We also have our references and resources there, and a call center. We've got support where you can actually reach out to us and ask questions. And so happy to answer those things. I spend the evenings answering emails and doing some phone calls and coding questions and administration questions. And so if you'd like to reach out through here, okay, got the poll finished up. And so excellent. That's great. And those of you who were interested, maybe we'll be getting somebody out to you. We'll share that with the people who need to see it. But we're moving on to some Q&A. If there's anybody that does have a question that they would like to ask directly, anything about coding, anything about insurance administration, happy to answer. We've got a few minutes left, and so I'm happy to get into that with you. I'll look at the questions that are already open and the things that are here. It's about how to code for when centrifuging blood and using blood products within the office. That is what we call PRF or PRP. Those are when we're taking the platelets from the blood and using a centrifuge to kind of create either our own biologic material or our own fibrin, which is used as a membrane. And so those particular things are coded using the D7921. That's collection and application of autologous blood concentrate product, I believe is what the total verbiage is. And so that is a covered service. In certain circumstances, you got to kind of justify why. With all the things that you're turning in, it's great to do a narrative if it's not just like Profi or something that's obvious and always covered. It's great to create a narrative that goes along with that. Talking about the new membrane codes, yes, there were membrane codes that had fallen in the, for years we used the same ones. It was 4266 for resorbable and 4267 for non-resorbable. And those membrane codes were used for any circumstance, any application. I think it was 2 years ago, 3 years ago, perhaps. Those were now broken up, and there are specific membrane codes now. The two that we were using before, the 4266 and 4267, are guided tissue generation or membrane codes that are specific now for around natural teeth. So the codes that we already had are still there, but they are periodontal codes. And so they're going to be used in a periodontal situation where we're retaining the tooth. There are two other codes, 6106, 6107. Those are for around an implant. So if you're using membranes around an implant, there's specific codes for that. And lastly, in edentulous areas, there's the 7956, 7957. Again, that's the resorbable variant, the non-resorbable variant for edentulous areas. That also includes where you just pulled a tooth. If you ended up just taking it out and that day you're putting in the 7953 bone graft for ridge preservation, that's that same day bone graft. If you're doing that and slapping a membrane on top, then you'd have to use that 7956 appropriate membrane code that would be from the surgical section now. So how our office is doing veneers on patients that have contracted insurance rates and fees are so low. Yes, that's absolutely correct. In fact, veneers are, most plans consider those a cosmetic service, and they're not even going to pay on them at all, but they do allow fees to be charged to the patient. Now, if it's usually not a covered service by insurance plan. And as a non-covered service, if it's, depending on the state where you're in, there's these non-covered service laws. There's 42 states right now that have non-covered service laws. If you're in one of these, veneers would normally be something that is never, ever paid for. And so it would fall under that never, ever law, and it wouldn't be a thing that they could dictate your fees. Now, if you are in one of the states where you do not have these laws in place, they do have the ability to tell you what the fee could be capped at. And so, but the vast majority of the country, not the case. You'd be able to do veneers and you balance bill the patient. In fact, more than likely, insurance is not going to cover veneering at all because it is cosmetic and it's fully out of the patient's pocket. You just don't want to be in the situation where that non-covered service is capped. By the way, there is a law going through Congress right now called the Dental and Optometric, what is it? Something. I can't remember the exact name. Is DOCS, D-O-C-S, what all it stands for. But this would take non-covered services laws federal. And so it would make it where insurances could not dictate your fees in any state. That is including self-funded plans and fully insured plans, which right now, self-funded plans don't even fall under those state non-covered services laws. And so even if you're in one of those 42 states, if it's a plan that is what we call a self-funded plan, it's usually a big insurer, somebody like FedEx or American Express or Microsoft, Walmart. Those particular companies, they fund their own insurance plans, and they don't fall under state laws. And so they still have the right to be able to dictate fees, even if you're in one of those 42 non-covered service states. So we'd love this federal law to go through. Contact your congressman. Ask them to push the DOCS Act, D-O-C-S. I'd love for that to be federal law. So facial abfractions or abrasions. Now, anterior composite resin codes, if you'll notice those codes, they do not say anything about the need for caries or erosion. Posterior composite resin codes, if you read those, they do require caries into the dentin or deep erosion. So for anteriors, you can still use the normal codes. Areas of abrasion, you're still going to be using the same coding. If you're placed in composite resin, you're using those composite resin codes, no matter what. But abfractions or abrasions, a lot of times, are not covered services under insurance plans, okay? And so in that circumstance, they may just deny it. More than likely, it would be allowed to be passed on to the patient. And so check your EOBs, look for, there's two words, there's deny or there's disallow. If it is denied, that means they're not going to pay anything, but you can charge the patient completely out of pocket. If they disallow it, that means that if you are in contract, then you're not even allowed to charge the patient for that particular service. And in that case, I wouldn't even do that particular service. So D0150, when can we bill to dental insurance? If you're looking at that code and you read the nomenclature of that code, it does say new or established patient. So as for a new patient, you're going to be able to do that anytime that you haven't seen that patient before. Established patient, there's language about that. If you read the criteria, it says if the patient has been, it can be reused, if the patient has been absent from the practice for 3 full years. Okay? That doesn't mean you can just use it every 3 years on every patient. No. The patient has to be absent from the practice for 3 full years or have major medical changes that would affect their oral cavity. So if they had new medication, if they were had a stroke, if they're now unable to use their hands the way that they could before to take care of their dental hygiene, those are all things that might qualify a D0150 being reused again. And if you are doing that, you can code for it. You can turn it in. A lot of plans, however, have plan document language that says they will only cover 150 once per patient per lifetime. More than likely what they will do is remap and call that a D0120 periodic if it is a patient of record already. But please learn about D0180. Like I said, go out and listen to that Dental Code Advisor podcast. If you're not using comprehensive periodontal evaluations within your practice right now for your perio qualified patients, you're missing big. That's money that you're just leaving on the table for doing work that you're already doing. And so absolutely go out and check that out. When is the best time to bill D0140? That is the limited oral evaluation. D0140 is, most practices are using that for emergency evaluations, which is absolutely correct. That's fine. Okay. But it's not just that. D0140 limited is when you're looking at any one specific aspect of the oral cavity and you're talking about it. So that could be an emergency that your patient's coming in and you're looking at one tooth that's hurting them and you're just doing the evaluation portion of that. Now, if you end up doing work that day on that particular tooth, they're probably not going to cover the 140 as an additional service to whatever the definitive service that you did that day. But it is a standalone code. It can be billed at any time, okay? Not all plans will pay for it, but it certainly can be charged. If you're out of network, you can always balance bill. You can always charge the patient directly. It does burn up an evaluation for a patient every time you use that 140. So that 140, if they've only got 2 evaluations per year and you do a limited evaluation, that may mean that they have a periodic evaluation that they're going to have to pay for out of pocket at some point later on in the year. So be judicious about using that particular code. Consider the palliative code, D9110. Palliative, if you're actually doing a little something to relieve discomfort on that patient, it may be better to bill that out as palliative and not do the 140 code for that emergency patient, because then you're not burning up one of their evaluations. They're going to have coverage for that at a later date. The palliative code would apply if it's just something that's it's relieving discomfort, but it's not curative, meaning you're not doing a crown, you're not doing the full-out root canal, but you're doing some small hands-on. It has to be something that you're touching the patient, small hands-on procedure on that patient to get them to feel a little better in the meantime. And if you've done that, palliative is an option instead of calling it a 140 for that emergency. So that is the end of the questions that got asked, and we are already about 5 over time. So Shirley, is there anything else that you wanted to talk to everybody about? I am going to put up the Business Solutions team address that's here. This is who you can contact for anything that we talked about today, the products, the services that we've discussed. You can learn some more by contacting this particular number. There's also this webinar link. This is going to be where these webinars live and exist going forward. And so if you haven't checked out this particular website, there are other webinars there that you might learn a lot from. So love for you to reach out from that. And with that, Shirley, I'm turning it back over to you.
Oh, wonderful. Thank you so much, Dr. Grobmyer. That was a wonderful presentation. And thank you everyone for joining us tonight. We have come to the end of our presentation. We also recorded tonight's webinar and we'll be emailing the recording out sometime in the next week to everyone who registered. We'd also appreciate your feedback via our survey that will pop up on your screen shortly. Thank you all again for
5 stars,
us.
everybody. 5 stars.
Yes, yes.
Right.
Get this. And thank you mostly, Dr. Grobmyer, for your incredible insight and organization. We look forward to seeing you and our audience on future webinars.
Thank you so much. Thank you for spending your evening with me, and we will see you soon. I appreciate it.
Have a wonderful night.